This next session is around nutrition, and questions about nutrition and dietary modifications are at the top of mind for parents when they first hear this diagnosis of Sanfilippo, and that it is a accumulation of glycosaminoglycans, which are sugar-like molecules. And so, the mind immediately goes towards diet. But there is really very little in the published literature about any specific dietary recommendations for Sanfilippo. But yet it's still an important area to think about, and to think about how we measure nutritional status, and if there is some general dietary advice that we could learn from other disease spaces or just in general that could help support our children's health. And I'm grateful that we have two experienced clinicians with us today from the Children's Hospital of Philadelphia to dive into these topics. First, we'll hear from Dr. Virginia Stallings, Professor of Pediatrics and Director of the Nutrition Center at CHOP. We'll then hear from Dr. Diane Barsky, who in her role as Associate Professor of Clinical Pediatrics and Gastroenterology established the Pediatric Feeding and Swallowing Center and now directs the Medical Enteral Nutrition Program at CHOP. Dr. Stallings, it's all yours.
First, I was saying I really appreciate being invited and the guidance that Kara and Glenn gave me in thinking about this. And then I did join the conference this morning, and certainly hearing about everything from the gene therapy and other potential treatments through the testimonials of the families was really quite amazing. And Kara, for those comments. So the idea of what I was going to do today, next slide, please, really is thinking of an overview, because as Kara said, there's not a lot in the literature. So I really offer you this as a conversation. It's considerations. It's not really data. But I want to look at these key components of how we think about malnutrition, nutritional issues in children with chronic disease in general, and then how we might bring this back to Sanfilippo's. Next slide, please. Now, you might wonder why I was invited to do this, but most of my work, most of my research in clinical care has been dealing with some of these very issues and diseases that are well recognized, certainly much less rare than Sanfilippo. But our research group really took the issue of nutrition and walked through it. And those diseases primarily have been cerebral palsy, which is not usually a genetic disease, but then cystic fibrosis and sickle cell disease, which are both genetic diseases, and actually have gone through a really amazing natural history change over the last 30 years. And I've been working in that area, and have watched new medicines come, malnutrition be reduced, life expectancy changes. So the way that we have looked at this is first to always start with understanding what the growth patterns are. And to do that, it's really about what equipment are you using, how well trained are the staff, getting those longitudinal measurements and plotting them on the right kind of growth chart, and then adaptations often for stature, because as in Sanfilippo, you can't always get a child with cerebral palsy to stand up and cooperate. As we get a bit more sophisticated, we're always more interested in the same way, not just for a weight measurement, but we want to know about body composition. We want to know what that weight is. So what is going into muscle development, fat stores, bone development, bone strength, and we'll spend a few minutes on that as we go through. Next slide. So then you go on to the other part of the nutrition equation, usually what are the needs of the patient or of the child, and what's being supplied. And that really can often be broken down to how much food does the patient need? How many calories does the patient need? And how is that compared with children who are typically developing and also how does it compare with what they're actually getting in. And I'll mention some fairly technical methods that we've used and could use, but just to give you an idea of how precise these estimates really can be. There's a method called total energy expenditure measurement where you use stable isotopes and you're able to capture truly all the energy that that person needs. It's the basal or the resting metabolic rate. It's the energy they need typically for physical activity. And in our children, it also includes that fairly small amount of energy that's needed to keep growth going at the proper rate. We can also use resting energy expenditure using a metabolic cart. And we've done this in any number of diseases. And from that resting or basal measurement, we can do a good estimate of total needs. Now that's measuring energy expenditure. The balance on that is how is food intake matching what is needed. And we have very good software programs that take the diet record from in a different way and converts it into how many calories in really every vitamin and mineral, amino acid. We can really estimate what was contained in the food. For this, we usually think of getting at least 3 days of information because sometimes a day is atypical and you don't want that to be the only data that you have. We use 24-hour recalls where we work with a caregiver and talk usually 2 weekdays and 1 weekend day and ask to go over every single thing that the patient had to eat or drink. Another approach is to do this prospectively. So we do what we call a 3-day food record, and we usually, in our research studies, provide the family with a food scale and measuring cups and are really able to get pretty accurate information there. And then food frequency questionnaires, which we really don't think have, it's not a good method for an individual child or small group of patients. So we tend to use the other 2 methods. And with this, we then can compare it with the software to what a healthy, typically developing child would need. And we have very solid national recommendations for how many calories and how much protein and each of the micronutrients it would be optimal for a typically developing child. So we can start to get a sense of what's needed by a child with a chronic disease, what they're actually taking in their daily food and beverage intake, and then how does that compare? So the next slide. So, often people think that there's a lot of great blood work, for example, that can be used to do nutritional status examinations. And it's really not true. We have just a couple of things that we find useful and that can track either deterioration or improvement in nutritional status or dietary intake. The 2 that we use most commonly clinically would be a serum prealbumin and a serum albumin. And each of those can tell us what the status is based on either prealbumin, which tells you how have things been going the last 3 or 4 or 5 days, as far as protein intake and calories, and the serum albumin, which actually reflects what's been going on over the last month or so. In certain cases, we look at essential fatty acids. There are 2 fatty acids that are very important to health, and they are essential for life. And we can easily get those now with fatty acid panels available for clinical care. And you can check amino acids, but the truth is, in most conditions, measuring the amino acids, excuse me, please, isn't very informative. So those would really be for some special questions. We've got good technology for measuring the fat-soluble vitamins, vitamin A, E, D, and K, a method for every water-soluble vitamin, every mineral that's really required. So if any of these nutrients become important, for example, in that they're deficient, or giving more of them might be useful, or they might in some ways become a biomarker, we've got very good technology for following that. We do spend a little time and interest on red blood cells, because there are several vitamins and 2 minerals that are absolutely essential for making healthy red blood cells. So, and iron deficiency anemia is still quite common in healthy children. And so we worry in any child that has an unusual dietary intake or limited intake that iron deficiency anemia may happen. But we also do see cases where the anemia is caused by a folate deficiency or a B12 deficiency, and some rare diseases and a copper deficiency. When you think about the white blood cell count, part of what you often hear us talk about the CBC, the complete blood count, which we red cells and white cells. There is an indication that's been well established about lymphocyte count, and a very low lymphocyte count being a pretty reliable measure of malnutrition. Next slide, please. So with all of that, then I turn to really reading a good bit about Sanfilippo, and I appreciate the guidance from the foundation, and did enjoy looking at the literature. And when you think about the growth issues, there is a good bit that's been described. You expect that a child who's going to later be known to have Sanfilippo is born full term, that they're appropriate for gestational age, they have a good weight and length and head circumference. And as I was reading through this, that made me wonder about, is there in utero heparin sulfate accumulation, and just what that's contributing, but it's not detected in any of these early signs. Then interestingly, there's in most of the reports of growth, and there are a number from different parts of the country that have looked at the growth velocity, both weight and height, and they find that soon, maybe by age 2 or 3 or 4, there's actually an increase in the growth velocity. So children with Sanfilippo, that may not have even been diagnosed yet, have a little bit of a growth spurt compared to other kids. And then later through the development, both the weight and height velocity, so how much you're gaining each year, slows down. And that often you will see the patients be a little bit shorter than you might have thought given their parental height and their genetics. Now, I say that having just watched one of the videos with a 6-foot-tall young man with Sanfilippo. So clearly these are all generalities. The other thing that's well established is there is an increased head circumference in later life, and that goes to be expected with the central nervous system and the brain changes and the increased ventricular size. Puberty, sort of the last part that as pediatricians we really think about in the growth story. Puberty is fairly typical. That onset is pretty typical. In female patients, the use of puberty delaying medications has been considered, and what the main thing there is to delay menarche and menstruation. For the boys, I don't think it's being used as much because there are no other sort of quality of life issues to think about there. And also, from a general pediatrics point of view, there are certainly well documented cases of growth hormone deficiency and thyroid deficiency, which can cause slowness in growth. And those are the kinds of things that with your probably with your metabolic disease specialist, that will be what you are thinking about. So next slide. So all of this comes down to often it's really easy to tell if a child is malnourished. This is a slide I've used for many years. And if you look at this, it's easy to tell that this little boy has been malnourished. You can see his ribs. You can see the wasting on his thigh. There's no muscle. There's no fat. And if you plotted him on a growth chart, he would show that he was underweight and short and probably has a low head circumference. On the next slide, though, it sort of shows the dilemma of this as a child. Again, if you look at his ribs, and if you look at that little arm where you see the skin folds and loss of fat and muscle, but the really large belly. So this is a child with a liver disease that also has ascites because of some of the manifestations, and the belly is really swollen and full of fluids. If you plotted this child on the growth chart, and you never really saw the child, he would look pretty normal on a growth chart. The last slide, clinical slide, is this is a little girl at CHOP many years ago who has cerebral palsy. And it was almost standing at the bedside with one of my dear colleagues who is the developmental medicine person. And we were arguing about, is this child malnourished? Is this just what cerebral palsy looks like with the, the thin legs and lack of muscle and lack of fat? And how would we figure that out? And I think that in some ways really leads to what is known and what might be done for Sanfilippo. So the next slide. So just to walk through this, and some of this might sound very mundane, but I will tell you in my quest with chronic diseases, these are some of the things that we need to know first, and really need to create an environment where things are done with accuracy, thinking of weight and height, that they're done longitudinally, like almost every chance you get, and that the care team plots the data on the growth chart, because without that, you really can't make any comments about growth or growth velocity. The next slide is just my pitch for, once the patients can't stand up, even with a scale that's got handrails, we are obligated to be able to get accurate measurements and need them to be done in the same way every time. So often that does mean that we have to get the patient into a hospital gown, out of the blue jeans and 2 sweaters, and heavy sneakers, and there are all sorts of equipment that can be used to safely get measurements for weight in people who are not ambulatory. Next slide. And then that takes us to stature. Again, as I have learned and certainly heard from all of you, as the children grow and get older, often part of what happens is a loss of communication, not being willing to communicate, to cooperate with things like measuring how tall you are. And again, our work in cerebral palsy really helped us with some of this, because we had to find alternative ways for those children who both couldn't stand and often had bone and muscle contractures, where you would never be able to get what the real height was. And I'd rather not measure height than to have something that really isn't at all accurate. So here, this was just one of several examples that are out there. We developed the method of using a caliper and very easy to determine landmarks to get a lower leg length. And next slide shows you the upper arm length. And then the next slide. And with my colleague Babette Zimmel, we went on to create growth charts that could really show you these are the growth patterns for healthy children. And then you would be able to plot the growth for children that needed alternative measures. Next slide. So then that moves us on to the issue of weight and height, but what else really goes to the body composition? And as I read through this, except, for a few organs, it wasn't really clear to me where the heparan sulfate accumulates all of the time, and actually how much might it contribute to body weight. It is, it's in so many different organs. So many of those organs get larger if you think of the liver or the spleen. But what really is the contribution? So that's something someone may know about, but that I really couldn't find. And also, I'm going to close in the end of being very interested in the patients having adequate fat stores, because to me that means they're getting enough food. They're getting enough food right now. Well, where is heparan sulfate stored, and is there any difference in the visceral fat or the subcutaneous fat? There's some studies going on looking at the metabolism of the brown adipose tissue. So I think those, again, are some fundamentals we don't know much about. The idea of could we non-invasively come up with an estimate of what fat stores are, and I'll show you the tricep skin fold method, as a simple, easy to do measure of adequate caloric intake. And then the other thing that really struck me as I worked through this, thinking of nutrition assessment, is certainly the loss of motor skills and the weight-bearing activity at early, as toddlers or early school-age children, has a huge impact on the muscle development and the strength of the muscles, and how to maintain that muscle strength over time. And the influence of those weight-bearing activities are even more pronounced or similarly pronounced on growing healthy bones. And the bone growth, both as it grows longer, and the bone strength in patients with Sanfilippo have a number of influences. There's the core influence of the family genetics. And again, I'll refer to the young man who was 6 feet tall, clearly expressing the tallness genes in the family. But also, to grow healthy bones, the weight bearing, what your body weight is. So skinny people have skinnier bones, how tall you are, and again, that issue of physical activity, and not only physical activity, but weight bearing physical activity. So I'll show you in a moment some modifications that we did of the DEXA technology to look at bone health in patients with cerebral palsy. So the next slide. This is just the slide to show you how you measure the skin fold thickness over the tricep muscle. And here you see the patient facing the other way. And again, the methods and really relatively inexpensive equipment that's been validated can really be used to help with this. The next slide. So I put this up because we at CHOP now 20 years ago were among the first to think about using DEXA technology. So this is what most of us think of as going to get your DEXA scan to see your risk for osteoporosis. And it was really developed for little old lady osteoporosis. But we've quickly understood that it could really give us what we needed, which is certainly a measurement of how the bones are doing, but also how much muscle and how much fat is in the body. Now, here is a total body scan. And, with this, I can tell who's right-handed and left-handed because of the muscle and the fat distribution. And when we were doing studies and we were near Halloween, we were always the favorite place to come because everybody would leave with their skeleton. But the next slide will show the idea. You can see in the right lower quadrant what the DEXA table looks like. And you can appreciate that many of our patients and children with Sanfilippo would not be able to stretch out on that and stay straight for that measurement, nor could the patients with cerebral palsy. So we developed a method where we could isolate the distal femur, and you see the x-ray of the bone above, with the right positioning and padding, and really have worked with this model, certainly for cerebral palsy, but with many other children that had contractures or hardware around the spine, things that would make using the standard testing inaccurate or not possible at all. And happy to say that we will have a new reference data paper for this out in the near future. Next slide. Now, to take the bone question a bit further, and again, I was intrigued by the idea of, are there going to be biomarkers that could be used that would be suitable? We moved to using the peripheral quantitative computerized tomography. And here you see it's a fairly small machine, but in our research lab, we were able to then look at, if you'll go to the next slide, really the details of the bone, because once you start thinking about bone health, you want to know about cortical bone, which is that very thick white bone that we always think about. But also the other important part of bone is the trabecular bone, which is this very lacy part that is very prevalent at the ends of the bones and almost non-existent in the middle. And we were able to characterize the bone health problems in each of the diseases we studied based on these kinds of things. And what risk was conferred for fracture, what was the best place to look for improvement if you were doing an intervention. The next slide. And just to take it so that you really can see what I find amazing about this. If you look at the panel on the left, so this again is the PQCT. On the left, you see the bright blue ring. That's actually fat. That's subcutaneous fat. And then if you look carefully, you can see that there's sort of the speckled red, which is muscle. And if we were there together, you could even see the different muscle bundles. And then the very bright white is the bone. So again, able to isolate different components that have different responses, both to illnesses and interventions. Next slide. So to go through then, the things I would really love to know are some of the things of like, what are the total energy requirements for patients? But as you've taught me, the patients go through very different stages of life and of deterioration. So I wanted to mention two other things that might have some utility in the fields. The gross motor function classification system, which I'll show you, and it has levels of motor deterioration. And excuse me. Level 4 actually is broken down to patients with more severe disease who need feeding tubes or not. And then to mention the feeding dysfunction scale. So the next slide. So this is readily available and pretty easy to classify. And this is based on looking at children's function between 6 and 12 years of age. And as you can see, and I'm sure looks very familiar, as you go from normal or almost no deterioration all the way through needing level 5 care. So the next slide. And then again, not a lot of time, but just to mention there are other ways of being able to classify the feeding dysfunction, not just it's fine, or they have aphasia, or why did we put in the G tube? And again, when we were doing our work, particularly in cerebral palsy, this became very helpful in describing where patients were and how they changed over time. So next slide. So to address the issue of basic things, and the issue really almost always is how many calories, because you're choosing good foods, family foods, or tube feedings that are well designed. The fat stores are going to reflect the calories. Protein intake, most of us take in much more protein than we need, although you can get to diet restrictions that make this limited. Fat, I mentioned there are 2 essential fatty acids that you do have to think about a little bit because you want those in the diet. But in general, most of your diet is made up of calories that come from fat, and you'd like those to be healthier fats or carbohydrates. I think the diet pattern things are something, again, we could think more about. And I know that everybody, food and eating and being together are some of the most important things that go along for families and children, especially those with diseases. You want to be able to feed your child. So thinking about how to maintain the family meals and cultural foods, real awarenesses of allergy and intolerance, which are quite different, food aversions, which certainly do occur in children with cognitive disabilities. And then also, how are you as a community thinking about the use of the gastrostomy tube? And to be sure that when you're visiting your healthcare team, that you talk about all the vitamins and minerals, herbals, anything that you may be giving the patient, because our understanding of what they might do help to be helpful is sometimes counterbalanced by what we're learning about what may not be as safe as we thought it was. So next slide. So the biochemistry screening, as I said, really the metabolic panel that you have to get all the time. There's limited use, but and serum albumin will be a part of it. The pre-albumin is almost never in a metabolic panel. And we use that, Diane and I would, in a nutrition support setting. I talked about the importance of making sure the red blood cells are healthy, and that's with or without Sanfilippo. The 2 essential fatty acids and the fat-soluble vitamins can all be routinely screened if there's an indication. Next slide. So the other thing I learned in going through this is actually bowel disturbance is fairly early in the symptom complex. That certainly it's the developmental delay and some of the ENT issues and ear infections that lead the way. But bowel disturbances were mentioned, like I said, pretty early in the story. As children progress, that motor function may or may not affect the oral motor function and lead to dysphagia at some point. And that there really are no specific dietary plans or recommendations for the disease at this point. And just to call out that the registered dietitians are a wonderful source if you're trying to implement something with some detail. But as I read about it, like I said, it doesn't feel like there certainly isn't a lot of evidence-based work yet. So on our GI side, these are all things to think about. GI reflux, the swallowing function, the self-limited dietary choices. We do see pancreatitis, GI bleeding, ileus and constipation, and also episodes of GI infection more associated with diarrhea. And all of those need to be evaluated if you think there's a possibility. Next slide. So I'll close with this. Again, one last piece out of the cerebral palsy study. In the state of California, in their Department of Developmental Services, they had over 1,000 measurements on about over 100,000 measurements on about 25,000 children. And we're able to create, analyze that and start to understand when weight becomes a major association with risk of death. And the next slide shows you that basic story. The first quintile and the darkest color would be those with the lowest weight. And this is using the gross motor function scale that I just showed you. And one of the things that surprised me, that even in the children with the least affected motor function, those at level 2, were already picking up a statistically different risk of death. And as you go through that, you see it gets higher. And then stage 5 without a tube, and without tube feeding, and then stage 5 with tube feeding. And you can see how that's just a stair step. Next slide. And the way that then they plotted this, if you look at the sort of pink to orange color, those are the standard growth charts from the CDC. And then the black lines show you the progression of the pattern of growth across deteriorating motor function. So this is in girls, and you see the 2, the 3, the 4, and 5 with no feeding tube, and 5 with a feeding tube. By the time you get to the 5 category, everything is shifted down. So just showing you the profound weight decrement in people, this girls with cerebral palsy over time. The next slide. And then what they did to make it easier for us as clinicians was to now overlay that information on top of what we think of as our typical WHO or CDC chart. So that as you're planning the weight, plotting the weight of people with CP, you can start to see when their risk is increasing. And there's a whole set of these charts for that condition, looking at weights and heights, and each of them scored by the motor function categorization. Next slide. So then really closing, the other question is about biomarkers or outcomes. And again, the hope and the promise of different therapeutic interventions coming down the way. I would suggest that one of the things that we'd like to do is to have the patients in the best growth and nutritional status that they could be for their whole lives until these things happen. And also to mention that you really, going into a trial, you would really like to have stable food intake and nutritional status so that you are not seeing changes related to that and inferring those related to the therapeutic intervention or disease progression. I read there was a lot of interest in metabolomics and proteomics and lipidomics and microbiome. And just to remind you that each one of these techniques are really just the modern metabolic take on what you're eating minus what you digested and absorbed. So for all of those to give you the best information, you again want to be sure that food intake and nutritional status are stable so that that doesn't give you background noise for these potentially important outcomes. Next slide. So this is what I'd like to close with. I don't think we know yet what the optimal intake would be across the disease progression cycle, but that could be figured out. We know that it is very unpleasant to be hungry, and in fact, painful to be hungry. We know that patients with a number of other diseases and in less developed countries, that if you don't have enough food, it's hard for you to learn. All of those things come together. And particularly here, I heard mentioned and read about communications around such things as being hungry or satisfied or having GI pain are not that easy to discern. And then lastly, I would encourage you as you go through this to think about using gastric feeding sooner than later. It can be used as a supplement to family meals. It can make oral intake sort of take the pressure off of that so that you can be sure that the patient's getting plenty of food. And also to evaluate when they occur, the diarrhea and constipation and the possibility that some of the pain is abdominal pain and GE reflux. And I'll mention again, I said, I started with CF, cystic fibrosis, a very long time ago. And during my career, we fostered that we needed to have better nutrition for the patients. And we succeeded. And we were able to demonstrate that with better nutrition and growth, the rate of the lung deterioration slowed down. The good news for CF is they've had huge breakthroughs with small molecule medicines. And what I feel like we help deliver is, as you were saying, Kara, we had a whole generation of patients with CF who were poised to take advantage of these new therapies. And in sickle cell, they're right on the verge of new gene therapy and stem cell therapy. So even in my career, I've been able to watch patients really go through this. Let's have nutrition be a little bit better, and maybe it really will contribute to the quality of life and the common good. So next slide. That's it. Thank you very much. And I think we're going to have questions after Diane presents.
Thank you so much to the foundation, especially the O'Neills, for inviting me to speak today. I'm so impressed how strong an advocate the O'Neills and the foundation are. And thank you again. It's an honor to be following Dr. Stallings, who's really dedicated her career to understanding children with chronic disease. What I'd like to focus more about is types of foods and how to think about what to feed your child in the current day and age. We don't know what causes or can reduce heparin sulfate accumulation in Sanfilippo. We're learning a lot. But in the interim, what can we offer our children so they receive good quality, balanced nutrition? Next slide. Next slide, please. Thank you. So I have a lot of slides and I really want to leave time for questions. So I'm going to focus on the key features of each slide and hopefully you can review on your own. So why thinking about maybe an anti-inflammatory diet for your child? Well, inflammation is important. It's the way our body reacts to protect us from contaminants from the outside, infection, bacteria, viruses, etc. And it protects us and helps us heal, whether we develop wounds or whatever's going on in our bodies. But sometimes the inflammation can cascade, especially if there's ongoing insults to our body. So you can think about it maybe in terms of you have a chronic infection, or you have an inflammatory disease, or you have toxic metabolites that may also cause inflation. Next slide. So what specifically is the anti-inflammatory diet? The goal is to break this inflammatory cascade, because inflammation itself, when it's chronic, can be destructive both to our neurologic system, some of our organs, of course, interfere with wound healing and our ability actually to fight infection. Well, it's a kind of a blend between the Asian and Mediterranean diet pyramids. So you could see for both the emphasis on physical activity, which can be in many forms, an emphasis on fruits and vegetables, and certainly proteins such as fish, some grains, but also when we think about these diets, most of the research has been more on the Mediterranean diet. And that's the type of diet I would like to focus on today and talk about the evidence supporting the benefits of this diet. But remember that the more natural the diets, and certainly there are other cultures, such as the Asian culture, that have also a lot of healthy anti-inflammatory aspects to it. Next slide, please. So when you think about the Mediterranean diet, I want you to think not only beyond it being a specific intake, but really a way of life, a pattern of eating that we see traditionally followed by people in the Mediterranean region, including Greece, Crete, southern France, and parts of Italy. There's no universal definition. It's a diverse range of foods eaten in season, and it's locally grown. It's all about family being together, enjoying each other's company. And when your child is able, maybe participating in some culinary activities, whether it's food preparation, watching how the food is harvested, being part of shopping in the local farmers market, and really being all together. Next slide, please. So what is the emphasis on the diet pattern? It is a plant-based pattern. It is rich in fruits, vegetables, whole grains, minimally processed cereals and foods, and legumes, such as beans, lentils. Think of all the different legumes that that you can have access to. There are sources of fat because, again, as Dr. Stallings mentioned, we need essential fatty acids. And not all fat is created equal, and not all fat is bad for you. So thinking about healthier sources that are less inflammatory: olive oil, olives, nuts, and seeds. There are also an emphasis on the different spices and herbs and garlic and onion, all used to put added to the food that in themselves have beneficial effects in terms of being anti-carcinogenic, heart healthy, good for supporting brain development. These diets still include sources of dairy and calcium, yogurt, cheese, different types of milks can be almond milk, oat milk, cow's milk, moderate ingestion of fish and shellfish. Another important intake of protein source, low in saturated fat. So looking at the types of oils used for cooking and other dips and also salad dressings. So the oils higher in the healthier omega-3 fats, which are anti-inflammatory, and a bit lower in the omega-6 fats, which are more inflammatory. And certainly still including eggs, which is the most balanced and complete source of protein, and white type meats as well, which have less saturated fat. Again, that saturated fat is inflammatory and contributes to premature atherosclerosis as well. Ensuring regular consumption of wine. No, not for children, but moderate ingestion of wine, which actually contains some phytochemicals, and less often smaller amounts of potatoes, red meat, cured meats, and sweets. So it's not never, but it's really looking at how it's sourced, what type of fats are fed to these animals as well. Next slide, please. So how does the inflammatory diet work? Well, there are phytochemicals in the foods and types of foods that are emphasized. These phytochemicals promotes an anti-inflammatory state so that when we're attacked by toxins in our environment, in our water, the pollution, um, whatever we're exposed to, they fight these contaminants and keep them from causing harm in our bodies. So berries, cocoa, and tea, especially natural teas such as green tea, black tea, protect against oxidative processes. These are, again, free radicals that can develop in our body that can be harmful and contribute to a rapid inflammatory cascade that is destructive. Well, these help prevent that or dampen the impact. Flavonoids are in fruits and nuts. Also, fruits and nuts and teas have anthocyanins and catechins. They're all protecting us against oxidative stress, reducing inflammation, and also improving vascular function, blood supply. Walnuts, actually, especially in terms of nuts, decreases the LDL cholesterol. That is the atherogenic cholesterol that can rise in our bodies in different inflammatory factors such as interleukin 6 and TNF alpha. Olive oil is high in oleic acid and monounsaturated fatty acids, which are the healthiest fats to have in our bodies that, again, interfere with the development and progression of atherosclerosis, anti-inflammatory, improves our lipid balance in our bodies. Lipids are important for producing new nerves and nerves in our brain that are surrounded by the myelin sheath. The myelin sheath wraps around our nerves in our brain to improve and facilitate signaling from nerve to nerve. And it's high again in those anti-inflammatory, healthy monounsaturated fatty acids. Polyunsaturated fatty acids are also healthier. And again, the mono and the PUFA are based on a chemical structure, based on bonds in our fats. And these are especially the healthier ones are the EPA and DHA, the omega-3 fatty acids that, again, interfere with excessive clotting, which clotting can contribute to strokes and heart attacks. It improves hemostatic regulation, so blood flow in our body, and also the omega-3s have a role in preservation of cognitive function. There are some studies showing that the omega-3 fatty acids can be helpful as part of the treatment of ADD and attention deficit hyperactivity disorder. The anti-inflammatory diet is high in fiber, both insoluble and soluble. It reduces your peak glucose, your glycemic index, reducing your risk of diabetes, helps with bowel movements and GI health. As I mentioned the red wine before, there's something called resveratrol, which also is an important antioxidant. And magnesium is higher in the diet, especially found in the nuts. that reduces inflammation and actually is good for brain health. Okay, next slide, please. So what are the benefits in children? Just as an overview, cardiorespiratory, reduction in obesity, less asthma, less improved lipid profiles, less inflammation in adolescence, some behavioral impact. There have been studies showing improved academic performance in school, a dampening of some of the sensory processing abnormalities we can see in the autism spectrum disorder, improvement of ADHD, as I already mentioned, and improvement in the microbiome, the colonization of bacteria in our large intestine, and reduction in fatty liver. Next slide. So why avoid ultra-processed foods? As you may have noticed, it's not mentioned anywhere in this diet. Well, when you think about ultra-processed foods, they're certainly not farm to table. They have a higher content of total fat, the saturated fat that we're especially concerned about, added sugars that we don't need, and lots of salt. And also a lot of other emulsifiers and other additives that are added to prolong shelf life and stabilize and keep from spoiling whatever's in the packaging. The packaging itself can have carcinogen factors and endocrine disruptors that may impact puberty. There are certainly food additives that we're not sure, but in certain diseases such as inflammatory bowel disease may have a factor in triggering inflammatory response in the intestinal wall. Next slide. So the benefits, more of the research has been done in adults, and certainly a whole host of improvements for atherosclerosis and cardiovascular disease, reduction in hypertension, inflammation, carotid atherosclerosis. We get plaque buildup in our carotid arteries going to our brain that can lead to stroke. And thinking about the neurologic impact, most of that research has been done in the elderly, besides what I mentioned, maybe for ADHD, and certainly in the elderly, it's been shown to improve memory, cognitive performance, less frailty, and depression. Next slide, please. So let's think also a little bit more. There was an excellent study in nutrients in 2021 that showed that the elder population that had the strongest adherence to the diet showed a positive effect on their cognition, even when they already had some impairments, proven in memory, improvement in cognitive performance, on objective testing, and also mental health improvements as well, especially in the area of depression. Next slide. And this is another study showing the harm of sugary beverages. Again, those added sugars that we don't need. Natural sugars are important. We need carbs in our diets, but not these sweetened artificial beverages. And it showed that, and this is a large sample size, followed over 9.5 years, that those people that developed dementia had higher intake of sugar-sweetened beverages and artificial sweetened beverages. Now, certainly there's a genetic and other risk factors related to the development of dementia, and there are different types of dementia, but certainly the more natural juice intake or more naturally it was obtained or sourced or produced, the less the risk of dementia. Next slide. So let's get into the nuts and bolts. We want to reduce our intake of inflammatory foods and increase our intake of herbs and foods to optimize brain health. And certainly you want to optimize brain health in your children as much as you can while fighting this unfortunate disease. Next slide. So let's put in practice. This is a good overview, and for the sake of time, I'm going to quickly go through the tips, which I encourage you to read on your own, but putting into practice. All right. A lot of us I've said already, so bring it all together. Avoid those artificial colors, sweeteners, high salt, high added sugars. You want to look at labels. You don't need added sugars, or keep them to 3 grams or less. Avoid these ultra processed foods as much as possible. So think about where you're obtaining your food. Whole foods. Try growing your own fruits and vegetables as you can. You want to emphasize whole grains, grains that are not stripped of their nutritional value, such as white breads and white rice. Healthy fats, again, the legumes, the beans, the lentils, chickpeas, you name it. And also make sure, even if it's ground up, the nuts, the seeds. Avocado is a great source of favorable fats for the brain, and that easily can be in a puree or a mash or added to smoothies. Next slide. All right, so it's a plentiful diet, but it's not plant alone. And I kind of want to quickly go through the next couple of slides to slide 20, please. Hello, can we go on with the slides, please? Okay, keep going. This is a healthy eating plate. I encourage you to read about, and you could find it on the Harvard site. Thank you. These are herbs, and the herbs can be very powerful on their own, as I already mentioned. And in fact, some of them are synergistic. For instance, if you make curries or other foods that combine turmeric and black pepper, together, both of them have strong anti-inflammatory and infective properties, but together they potentiate each other 1,000-fold. Now let's go to slide 23. I'm mentioning a few B vitamins to think about that your child, it's okay, you can go on, need to have, and they should have it through their diet or be supplemented if they need a multivitamin that impact the brain, and when deficient can cause their own neurologic issues and depression. Thiamine B1, please keep going. B3, niacin alone, when deficient, can cause dementia and depression and confusion. Next slide. Vitamin B12, as Dr. Stallings already recommended, has impact on both your peripheral nervous system, so paresthesias in the hands, muscle movement, but within the brain, deficiency can cause personality changes, dementia, even psychosis, and I've seen it. Next slides. These are ideas about sources of B12, and let's keep going. I have some information thinking about calorie boosting. This is not to replace the balance in their diet, but to enhance calories in a way that is healthy. But it is relying heavy on fats. Keep going, please. And these are other foods and things to think about to add calories. Next slide. Oh, nutrition supplements, I just want to mention. Think of them as they can be a friend. There's so many. I would collaborate if you can with a dietitian. But again, these can provide protein, carb, fats, vitamins, minerals that your child may need if they have a very selective diet or eating small amounts. Also, they're appropriate if your child develops dysphagia, swallowing dysfunction, that they could be provided these different supplements, and even food-based products are out there that can provide balanced nutrition. Please go ahead. I just want to mention, next slide, is that pediatric feeding disorders I read can occur in Sanfilippo and many developmental disorders that would benefit from a feeding team, because feeding skill development does parallel overall gross motor, fine motor, and development and communication. Please go ahead. So thinking about feeding paradigm, ideally, and this is modeled our team at CHOP, we have medical providers to look at underlying GI function and other medical issues that may be contributing to poor nutrition or increased needs. This behavioral psychologist will look at and help work with the children that have very narrow diets to help using behaviors to reinforce acceptance. And then certainly the speech and occupational therapists look at safety of swallowing, mechanical changes to the diet that can optimize safe swallowing, and again, look at optimal positioning and posture as well to keep feeding safe. And of course, nutrition, looking at diet quality, balance, and ensuring that there are no increased risk for deficiencies. Next slide. I just want to reiterate the Sanfilippo syndrome guidelines, which were very impressive, published in 2022, that covered so many aspects for the child and adolescent adult. So overall, they emphasized a healthy diet, which I quickly reviewed and can provide references, and you'll have these slides when needed. If any concern about swallowing, chewing, is working with a licensed speech language therapist. Child may need a video fluoroscopic swallow study, ideally done with the radiologist and the speech therapist. Think about referral to the dietitian. These are two studies discussing retrospectively looking at adults with Sanfilippo, and again, as Dr. Stallings already discussed, looking at differences in growth. I'm sorry for going over, and I really want to emphasize questions and answers. Thank you very much.
Thank you, Dr. Barsky and Dr. Stallings, for the really incredible and in-depth information that you gave us about nutrition and how we can think about our kids' health in that aspect. We've had a few questions around some things related to kids' growth and observations that really we commonly see that you touched on, and some references you made in your last slide, Dr. Barsky. And Glenn, if you can put the one slide up, I think it's pulling from one of those references that you mentioned. This is the BMI, so just kind of reduced it down to the BMI from the German study, Dr. Muschel and colleagues published looking at Sanfilippo patients over time. And this is really just what families in the chat were talking about, that initially there are those, the kids are bigger early on, and then growth tapers off, growth and weight taper off. And tomorrow we'll be hearing from a scientist who has done, some work looking at metabolism in the fat tissue, Dr. Stallings, you referred to. So that will give us some more additional insight as to why we might be burning maybe more energy than a typical individual without Sanfilippo. And so maybe those energy requirements are just higher at baseline, which gets into, some of the ways that we can measure that. And I was wondering, Dr. Stallings, what's really involved in doing an isotope study? How would you do that practically?
No, that's a good question. I would like to say one thing about the BMI charts. I always encourage us to look at the two elements separately. BMI is a really good measurement sort of for epidemiology kind of work. But from a growth perspective, what you're really interested in is how is the height going and how is the weight going. But the patterns you're showing, are integrated into that. We often see if the height is going to be delayed. In some conditions, the kids end up eating more and getting chubby. It looks like it's very mixed in Sanfilippo. Some children have more difficulty getting enough food. But back to doubly labeled water. So that's just my pitch, whether it's obesity or failure to thrive, the importance of both elements. So what's involved? These are stable isotopes, so there's no radiation involved. You give the dose in a few cc's of water. It's tasteless, odorless. And then you generally, depending on the age of the patient, would collect urine a couple of times. Well, wait, first you collect urine before you give the dose. And then you collect it again a few hours after the dose, so while you're together. And then you collect urine either over once or twice over 7 days or 10 days or even 2 weeks. But we tended to use the 7-day or the 10-day, and that depends on what you anticipate their metabolism to be. And the urine, I've done studies where I had to collect the urine in diapers and squeeze out the urine, or in the young boys, using the catheter, the condom catheter, which is, non-invasive. But, we've done it in infants, we've done it in, adults. And then it goes to a lab that does the, if you will, measuring how fast both of the isotopes are used up. And from that, we can calculate calories per day. And it really is total. This is the one thing that captures physical activity, growth, and basal metabolic rate, and actually energy to digest food. So,
are these measures available generally across the country and the world, or are they really more specialized?
Well, they're really research tests. So they would need to be done in that setting. Okay. And I think if you're thinking about that, the idea would be to think about having a study where you had a certain number of children at each of those stages of really cognitive and physical development. It's going to be the brain is actually the organ that uses the most energy. But I mean, a study could be designed to do this, and it wouldn't, it is one of the more simple things. Doing the metabolic cart requires much more cooperation and that sort of thing. But I'd be happy to talk to you or your, other team members or investigators. But I think that and getting a true estimate of what food is being eaten right now, and to Diane's point, what's the diet? I know that, often it's just whatever you can get in them. I mean, it starts out there in the family meal pattern, but this can be very complicated and often ends with a structured nutrition product, through a gastrostomy tube. And we have a lot of confidence in that. I mean, those are well-designed products.
Yeah. Yeah, it's a really interesting concept to think about also, how much does heparin sulfate storage contribute to weight? I
really
that's a really interesting, thing to think about.
Right.
And because in some studies, where there have been, enzyme replacements or gene therapies, we see organ, resolution of hepatosplenomegaly.
Right.
We even see a reduction in initial reduction in brain volume thought to be purging of that storage, and then stabilization and even gains after that. But so it's really interesting to kind of think about
I think, again, and as you go to, we hope disease modifying curing therapies, these could be important things because the heparin sulfate goes away. You probably lose some water with that, and I think having a good handle on weight and storage, and not being, I mean, there could be some observed outcomes that would make us worry that may not be worrisome. For me, if people start losing weight, of course I get worried with chronic diseases. But I think all of these are avenues that without a lot of effort or money, in the sense of the money for the cure, we want to be able to help demonstrate. So yes, that hit me right off. It's like, well, why, is this in the muscle? Is it in the fat?
Right.
It has to be in the liver and the spleen. It has to be everywhere. We have lysosomes everywhere. So
right.
How do we look at body composition?
Yeah. Yep. And Dr. Barsky, thinking about combining spices or combinations of foods that give us that synergistic or extra boost to the healthy component of them, particularly when it comes to like oxidative stress and inflammation, which we know are component drivers of the disease process. Yeah, it's really interesting, and things that are accessible to us as parents. Yes. To just support our kids to be as healthy as they can. So thank you for the great information.
You could really flavor foods without using so much salt, that you can use a lot of these, and it's beneficial to the whole family. That's what I like, about thinking about the diet that way and how you cook.
Yeah, kids can inspire us all to be healthier, probably. Yeah.
Good. Well, you guys have a lot of stress. So I want, we both are very much, how do you put what we're talking about into the context of all the other things that you have going on? But we were both honored to be with you. And like I said, I really enjoyed the morning. We'll be in touch. Thank you. Thank you all.
Thank you both so much.
Okay.
Bye-bye.
Thank you.